my presentation about kidney functions and electrolyte disturbance among Iraqi patients with bladder cancer. First of all, I want to clarify some basics about bladder cancer. So let's identify bladder as an organ. Bladder is a hollow muscular organ with tetrahedral shape when it's empty and spherical shape when it's full of urine, and it lies in the frontal part of the pelvic. So the bladder's main function is to store urine. As we see here, we have empty bladder and full bladder. Second, I want to identify tumor. Tumor is a self-controlling growth formed by unlimited multiplication of abnormal cells in the one of the body's organs or tissues, and it has two types, malignant and benign. Today, our case is all about malignant tumor located in the bladder, so it is a bladder cancer. It includes a spectrum of illnesses ranging from superficial to aggressive invasive forms. Urinary bladder cancer is the cause of about 300% of all new cancer diagnoses and 2.100% of all cancer deaths. In advanced bladder cancer, the obstruction in the outflow of urine from the kidney leads to reduction in the filtrating capacity of the organ, which results in an increase in concentration of serum creatinine and urea, which are the routine serum biomarkers commonly used in the clinical practice associated with renal function. Due to increase in cancer cells cycle activity, it is expected that change in the purine and metabolism pathway would be seen. This will eventually lead to increase in the serum uric acid levels. Electrolyte disorders are common in cancer patients, and often the alteration in the asymptomatic are asymptomatic. However, they can lead to serious complications, negatively affecting quality of life, treatment response, and survival outcomes. Materials and methods. Our study is a case control study. Involved 100 individuals with 16 to 79 years of age. All individuals were enrolled from Ghazi Al-Hariri Hospital for surgical specialties. The 100 individuals are divided into two groups. The first group is a patients group, involve 50 patients, 46 males and 4 females, who first diagnosed with bladder mass and investigated by TURBT, which is transurethral resection of bladder tumor, and sent to the hospital the histopathological examination for biopsy. The second group is a control group, which involve 50 healthy individuals, 46 males and 4 females, those who have normal bladder tissue with no previous history of any other renal system diseases. The inclusion criteria, patients with who presented with a bladder mass. Exclusion criteria, patients with other health disorders that make them unfit for general anesthesia. Results. As we see here, we have this table showing us the mean and standard deviation values for biochemical tests of the study groups. As we see, we have significant statistical difference in blood urea, serum uric acid, serum calcium, and serum sodium between the two groups, cases and controls, or patients and controls, depending on the B value. As we see here, we have 0.001 or less than 0.001, while we have no significant difference, statistical difference, in serum potassium and serum creatinine between the two groups, the cases group and controls groups, also depending on the B value. Discussion. The absence of statistically significant difference between the levels of serum creatinine of the two groups in the present study is in disagree with the results of other studies where their patients were in the advanced bladder cancer stages and the kidneys impaired ability to filter urine results, rising in the concentration of creatinine. Although the patient's blood urea concentration were within the upper limits of the normal range because most of the patients in this study had low-grade tumors with small-sized bladder mass. The serum uric acid level were in the upper limits of the normal range with a significant statistical difference because most of the patients were in the hypermetabolic states. Our study found a significant difference between the patients and control groups in the serum calcium and serum sodium, but not in serum potassium. These concentrations were in the upper limits of the normal range because most of the patients in this study had low-grade tumors with small-sized bladder mass. Conclusion and recommendations. All renal function tests were within the upper limits of the normal range, as most of the bladder tumors were low-grade, small-sized masses. This study highlights how critical it is to keep an eye on and treat electrolyte imbalance in the bladder cancer patients because these patients can experience electrolyte abnormalities for many reasons, including cancer physiopathology, anti-tumor therapy, and other clinical conditions or therapies. Thank you very much. And any questions, I am ready.
Dizay from Erbil, Kurdistan of Iraq. And our presentation is about the pathological significance of HRAS gene mutation in colorectal cancer patient in Erbil province. So as we know, now the colorectal cancer or CRC is one of the most dangerous, commonly occurring malignancy in our country, especially in Middle East and also in European. It is I think it's now become the trend for the gastrointestinal tract malignancy, and it is the second among women and the third among men. And also the CRC is second among deaths caused by cancer. Globally, the incidence of the disease reached 1.8 million in 2018, and now, depending on the WHO report, is maybe this number is become 1.9 or 2 million. Sorry, I didn't have the real data for this last 2 years. And the new cases of CRC are expected to exceed 3 million cases in 240. They expected that because, as we know, everybody now, especially in our poor country, in our limited country, there's different problem, different negative feedback about all of the life problems. So it is increased the risk of CRC. In Iraq, the burden of CRC is 7th among cancer problems, whereas in the Iraqi Kurdistan region, the CRC is the 4th cancer burden in both sexes. Is the sound okay?
Doctor, we can hear you. The presentation is clear. It's fine. Please continue.
Okay. Colon cancer is often sporadic and related to risk factors such as age, race, diet, and the presence of inflammatory bowel disease. And anatomically, CRC usually occurs on the right side of the colon, the left side of the colon or in the rectum. The pathogenicity, prognosis exhibiting distinct molecular characteristics and histology of cancer on the three sides are not the same. Sporadic reasons have roles of 70 to 80% in CRC, while heredity has around 20 to 30% caused in the disease development. The risk of CRC is associated with obesity, the first problem in many countries, developmental and low country, lack of physical activity. Also, this is now come lack of physically. Everybody sit on the computer, sit on everything by internet, by delivery by internet, taking everything by internet now today. Smoking, especially those nargila, al-vape, alcohol consumption, and unhealthy eating patterns, fasting food, including consumption of a high amount of salt and red meat. In addition, the risk of CRC is higher among persons who have positive family history. As everybody know that the who has positive family history for all type of cancers, not only for CRC, it is has most chances to become considered for risk high, and it has a higher risk than which who have no family history. Patient with a history of colon polyps, inflammatory bowel disease, diabetes mellitus, colostomy, gut microbiome, and aspirin exposure. All of this considers as a high risk for CRC. And evidence indicates that 3 were 2 causes of stimulating tumorigenesis, which is maybe chromosomal instability, CIN, or microsatellite instability. Sometimes it involves many proto-oncogene, tumor suppressor gene, and also epigenetic change in DNA. With reference to the molecular installation of human cells, there are 3 kinds of closely linked RAS genes in human cells, called HRAS, HRAS, Kristen RAS, and neuroblastoma RAS, which is abbreviated as NRAS. Above the molecular background, which is now around worldwide, it's the potential technique for detection the cancer. RAS proteins are known as a small GTPase involved in broad spectrum of key molecular and cellular function, including diffusion and survival. At some time, the gain of function missense mutation, which is commonly located at codon 12, 13, and 61, stimulates RAS proteins. And these proteins can be observed in the cancer cells of human. KRAS is considered as the most commonly mutated, followed by NRAS and then HRAS. Depending on the several articles which done around the world, they consider as KRAS is the most commonly mutated in colon cancer. RAS genes are among the earliest mutated genes in the majority of cancers. Studying mutation pattern can help the medical team to understand. As we know, the mutational and molecular studying or immunostudying help the doctor, help the physician, help the staff of chemotherapy to decide and to decide therapy the targeted point. Now, as we know that immunotherapy is very commonly known, maybe 10 years, last 10 years or last 10 years, they use it immunotherapy to treat the patient with cancer because it is more sensitive and more detect only detect the region that's causes with the cancer, not all of the body. And because of the modern orientation in diagnosis, treatment, and study progress of malignant tumors, including CRC, depending on study mutation in the genes. So my present study tries to find mutation in the region surrounding HRAS 12, 13, 61 codon, and commercially available real-time PCR formalin fixed paraffin embedded for CRC tissue. And as we know, this search before 3 years we done it, and now there is another technique, as we know, it is take a cost and very expensive in our country, next generation sequence, but it is very, very, very strong and sensitive to detect the sensitive genes. And when we take a whole exome gene or gene for the patient, around 25,000 gene by next generation sequence, it is more accurate than real time. But as we know, it is expensive. Methodology, clinical characteristic of 70 patient was collected from the hospital and survey using a standard questionnaire. The data was obtained from our teaching hospital in Erbil. The demographic and clinical characteristic of patient now shown in table 1. And 20 are formalin fixed paraffin also of colorectal cancer are selected for molecular analysis by real-time PCR. Genomic DNA was isolated from 10 micrometer thickness using QAM DNA extraction kit. This is the method. I think it's not so important, necessary. The DNA concentration was determined at 260 nanometer by using nanodrop spectrophotometer using Thermo Fisher. Polymerase chain reaction using thyroid kit, easy thyroid kit for identify HRAS mutation in this codon, and the statically packaged for social science version 26 was used for data entry and analyzing this descriptive statistical analysis. Patient demographic and tumor characteristic. The mean age of the study sample was 52.23, as here we show. And with standard deviation, 60.23, the range of age was 7 to 82 years. We have one patient, 7 years. The distribution of the sample according to sex, male, female. The male ratio to female ratio is 1.8 to 1. Most 94.3% tumors were adenocarcinoma type. Concerning the size of tumors, the majority, 72.9%, were less than 4 centimeter, and 18.6 were more than 4 centimeter, and 70% of tumors were positive for vascular invasion, and 72.9 were positive regarding the nodal state. 61.4 of tumor are in grade 3 and 30 in grade 2. And this is the table 1, age, sex, clinical and histopathological feature of colorectal cancer patient. Age and sex, the location, rectum, ileum, sigmoid, large intestine, proximal, distal, and the hemochromia, canal cancer, mid-rectal, all of this, the position and the size per centimeter, more than 4 or less than 4. Tumor type, adenocarcinoma, mucinous carcinoma, hyperchromatic, and the grade, first, second, third, and vascular invasion, nodal state, all of them was described. HRAS mutation results, only a single case of positive mutation in the HRAS gene. The mutation was in female, age 32 to 48, with a sigmoid location. The size was more than 4 centimeter, and it is an adenocarcinoma type of tumor. The tumor is in the third stage. There was a significant difference between the size of the tumor and the positive HRAS mutation. No significant association with age, sex, tumor location, type, stage, grade, or nodal status was seen. And this is the table 2, HRAS mutation, and it is association with age, sex, and clinical histopathology. As we see, age, more than 32 to 48, one mutation positive. 49 to 65, no, only negative. And the female, it's one female, as we mentioned before. And the tumor type, adenocarcinoma. Discussion Most CRC cases in study aged 52 to 71, male predominance, majority of tumors were adenocarcinoma, proximal location, advanced age, vascular and nodal involvement. HRAS mutation rare, but may be linked to larger tumor size. We needed literature supports of HRAS mutation in CRC, more research needed. And conclusion, HRAS mutation found in 5% of CRC case studies, tumor size significantly associated with HRAS mutation, and further study needed to clarify clinical significance, especially if it is used by a new technique such as next generation sequence. And thank you.
Yes, please.
Okay. And the background. Substance use disorder has emerged as a key health and social challenge in South Africa. It is projected that about 15% of South African youth, especially young women, are prone to engage in drug use and prospect of encountering nyaope. The highly addictive drugs are higher. Nyaope is mainly smoked, but prevalence of injecting it is increasing in most regions. Next slide. Substance use disorder, SUD, has emerged as a major public health and social issue in South Africa, with children as young as 8 years old reporting using nyaope. The SUD has presented itself as an overwhelming challenge both globally and in South Africa. It is a complex challenge that undermines the social fabric of humanity and has a negative impact on the lives of both users and non-users alike. Social pressure, peer pressure, and dysfunctional family, genetic factors, emotional problem, mental health problem, loss of respect, trauma, experience, loss of livelihood prior to substance exposure have all been identified as contributing factors to SUD. It is projected that about 15% of South African youth, including young women, are prone to engage in drug use, and the prospect of coming into contact with nyaope are higher. The use of nyaope has a significant impact on one's health, society, and finances. Nyaope also causes irreversible mental and social harm to the individual. Next slide. Despite the rise in the prevalence of nyaope through smoking, the injection in South Africa, the South African government has not fully embraced the harm reduction approach as one of the framework for addressing the public health concern that are unavoidably associated with the use of nyaope. Nyaope is one of the drugs that is of concern in such program, as COSAP nyaope is a trendy new drug popularly in South African township. Nyaope full composition is unknown, despite the fact that most researchers agree that heroin is the primary ingredient, with rumors of antiretroviral treatment medication being documented. It is reported when users attempt to stop using nyaope on their own, they experience severe withdrawal symptoms, such as severe unbearable abdominal cramps. Although nyaope was rolled and smoked with cannabis in first place, it's a growing trend of dissolving nyaope in water and injecting it directly into the user's vein. Next slide. The process of transition from smoking to injecting is viewed as a process of coping with a variety of resource constraints and a process of curiosity and pleasure seeking. Nyaope injection is presently an increasing trend in most regions in South Africa. Baluka Wamala found that women are easily influenced by their male peers and clients to transition to injecting, especially if they work in the sex industry. Women who use drugs are more vulnerable than men to HIV and other blood-borne infections, not only for biological reasons, but also because of gender power disparities. For example, being incapable of discussing condom use, being injected after an intimate male partner has injected himself with the same needle, being involved in sex work. The injecting practice, as compared with smoking, comes with countless risks and personalities disorders. It is well understood that mental health issues lead to drug use. Next slide. Substance use disorder is a multifaceted problem caused by the variety of factors. It requires a variety approach. It presents a unique challenge for police and other law enforcement agencies. As you do, should be addressed to assist people who use drugs, rather than arresting and prosecuting them, thus requiring an integrative approach to address nyaope challenges in the communities. Users' challenges, coping resources, experience, risk needs, hope cannot be addressed without involving them in the process. Despite an alarming increase in substance abuse among women around the world, the issue is largely ignored and neglected. Such ignorance is puzzling because women who inject drugs face greater stigma than their male counterparts. Women who use drugs are rarely the subject of research. Their reasons for use are unclear and poorly understood. Policymakers will appreciate the complexity of SUD if the researchers and practitioners has a clear understanding of the reason why women use drugs, rather than assuming that drugs use is merely a matter of individual choice, that abstinence and prohibition can solve rather than symptoms of social problems. Next slide. Next. The study aimed to explore and describe the women's perception on factors contribution to nyaope smoking and transition to injecting nyaope among women in the city of Tshwane Municipality in Gauteng. The study design. Qualitative methods were utilized to explore and describe the women's perception of factors contributing to nyaope smoking and transition to injecting nyaope among women in the city of Tshwane. Qualitative research is commonly used when research aim is to obtain an understanding of people's perceptions about the world. Furthermore, it is used to answer questions about people's experience, perspective, and meaningful from their own understanding. Qualitative research method was the most appropriate research paradigm because it allowed the researchers to focus on describing and understanding factors that contribute to nyaope smoking and transition to injecting nyaope amongst women residing in the city of Tshwane, rather than explaining factors that contribute to the use of nyaope among the city of Tshwane women in the women themselves experience. Next slide. The research questions. The following research question guided the study. What are the women's perceptions on factors contributing to nyaope smoking and transition to injecting nyaope amongst women in the city of Tshwane Municipality? The study took place in COSAP site across the city of Tshwane Municipality. Data were gathered in 8 of 17 COSAP sites across the city of Tshwane Municipality. Prior to visiting further COSAP sites for data collector, the researcher reached data saturation. Community-oriented substance use program was established on a system thinking, harm reduction approach to public health and clinical care. It seeks to provide evidence-based substance use services integrated into community-oriented primary health care. Next slide. The population of this study were women above the age of 18 years who reside in the city of Tshwane Municipality with a history of injecting nyaope for more than 6 months. The participants were accessing harm reduction services at COSAP sites across the city of Tshwane. The purposive sampling method was used to recruit participants from COSAP needle syringe exchange program and opioid substance therapy social work caseload. All women accessing services at COSAP with a history of injecting nyaope who meet inclusion criteria were invited through the assistance of the site social workers to participate in the study. The researcher sampled 24 participants from the population with the help of the site social workers. 15 women were currently injecting nyaope, and 9 women in the history of injecting nyaope were interviewed. The researcher was more interested in interviewing women who had a rich life experience of the phenomena being studied in the case of experience of using nyaope injection. Next. Permission to conduct the study was granted by COSAP management before data was collected. The researcher liaised with the site social workers for data collection. In preparation for data collection, the social workers handed participants consent form and assisted those who could not understand English with understanding the content of the form in their own language. The consent forms were written in simple English, free of jargon, and legalese for participants to comprehend the meaning before participating. The researcher also checked with the participant if they understood the purpose of the research before collecting data. The risk, benefits, rights were discussed in the presence of the social worker before they consented to participate in the study. Data was collected using semi-structured interview with 24 participants. All the interviews were audio recorded and the interview were kept safe to protect the information and maintain confidentiality. Next slide. Data were analyzed using 6 steps, thematic analysis identified by Brandt and Clark. Phase 1, the researcher acquainted themselves with the data. Phase 2, the researcher generated initial code. Phase 3, the researcher searched for themes. Next slide. Phase 4, the researcher reviewed themes. Phase 5, the researcher defined and named the themes. Phase 6, the researcher produced the report. Next slide. In terms of ethical consideration, the article is part of master's dissertation entitled Exploring the Experience of Women Injecting Nyaope Residing in the City of Tshwane Municipality, Gauteng. It was approved by the Research Ethics Committee of the College of Human Science, University of South Africa, with the reference number of 2019 CHS 0246. Permission to collect data within COSAP site was granted by the University of Pretoria, Department of Female Medicine. All participants provided informed consent to participate in the study. The participation was voluntary and the researcher adhered to social science ethics throughout the study. Next slide. Measures to ensure trustworthiness. The first one was credibility. Confirm that the results of qualitative research are credible or authentic from the participant's perspective of the study. The finding must reflect the views of the participant as they were shared by the participants. The researcher enhanced credibility by building rapport with the participants. By transcript verification, 4 transcripts were taken for participants to read through and confirm the information as the interview were conducted in Sepedi, which is the local language. 2 participants who were under the influence of substance at that time of the interview were not considered. Next slide. Transferability. The researcher has interviewed multiple participants from different areas within the city of Tshwane. The researcher has audiotaped an interview and observe and explore non-verbal message during the interview to make sure that the transferability is being maintained. In terms of confirmability, confirmability is described as the level into which the results can be confirmed or corroborated by the other researchers. Reported that confirmability captures the traditional concept of objectivity. Confirmability was captured by audio recording of the participant following up on question probing and not assuming what the researcher did not understand. Next slide. Dependability. This is described as whether the same results will be achieved if the same phenomena is observed twice. Qualitative researchers promote flexibility and freedom. Stated that the researcher should ask whether the research process is logical, well documented, and audited to improve dependability. As a result of high cost, the researcher could not appoint an independent co-coder instead of the supervisor as an experienced qualitative and mixed method research assisted with co-coding to ensure dependability. Next slide. The results were collected from 24 women with the history of injection nyaope. 2 main themes and 11 sub-themes were created. The first theme, it was factors contributing to the smoking of nyaope. And the factors contributing to smoking of nyaope were identified in this study. The first sub-theme, intimate partner influence. Participants report that they started using nyaope with their intimate partner. One participant alluded that the desire to spend time with their intimate partner contributed to her decision to use nyaope. The second sub-theme, peer pressure. Peer pressure and sense of belonging contributed to nyaope use amongst women. Friends play a crucial role in introducing women to substance abuse. Some participants reported that they started to use nyaope with friends, smoking daga with friends, cultivate a ground to initiate nyaope use. It makes it easier to try new drug, including nyaope. Next slide. Peer pressure, the third one. Peer pressure and the sense of belonging contribute to nyaope use amongst women. Friends play crucial role in introducing a woman to substance abuse. Some participants reported that they started to use nyaope with friends, smoking daga with friends, cultivate a ground to initiate nyaope use. It makes it easier to new drug, including nyaope. One of the participants further reported that a desire to feel she belongs to or fit her social group influenced her decision to use nyaope, as she did not want to be considered uncool or the need for acceptance for the participants in drugs. Next slide. Being misled by friends. Some participants have indicated that friends misled them into smoking nyaope. They were not aware that they were smoking nyaope when they started to smoke nyaope. They assumed they were smoking daga, only to discover they are nyaope and mixed drug with nyaope. Using nyaope for weight loss. There was this perception that weight loss can be identified as a factor that influenced participants to start using nyaope. Their initial idea was to lose weight, but they got dependent on nyaope and continue using it. Some participants exhibited poor decision-making process in their pursuit to lose weight. Next slide. Lack of effective coping mechanism. Most of the participants reported that they started using nyaope because of issues they were facing in life, challenges in life. Participants started using nyaope as coping strategies to deal with their stressful events they were experiencing in their life. One participant spoke on how she witnessed the murder of her father, while another talked of rape by her adoptive father and rejection. The incidents influenced them to use nyaope to cope with what they have experienced. Next slide. Counteracting other drugs. The participant started using nyaope to counteract other drugs. Participants were using cocaine, which is a stimulant. They introduced nyaope to mitigate lack of sleep as a result of cocaine use. It was never their intention to be the regular users, but because of addictiveness of nyaope, the participants were later dependent on nyaope. Next slide. Next slide. Theme 2, factors contributing to transition from smoking to injecting nyaope. The factors contributing to transition from smoking to injecting nyaope were second theme identified in this study. The first sub-theme, need for intense high. The need to experience an intense high lasting longer has influenced participants to transition from smoking nyaope to injecting it. The transition from smoking darker to injecting initiation was based on the need to increase the drug's effect. The majority of the participants indicated that when nyaope is injected, it gives a high faster than smoking nyaope. The need for intense high contributing to the transition. Next slide. The second sub-theme, intent partner influence. The participants were influenced by their intimate partners to transition from smoking nyaope to injecting. The influence of intimate partners on initiating injecting nyaope should be acknowledged. Such an influence increases the risk of female nyaope injectors contracting HIV and other blood-borne infections. Next slide. Influence to social network. Participants were introduced to injecting practice by people in their social circle who were already injecting, the friends, women who use drugs, in order to gain a better understanding of their experience. The finding demonstrated that an intimate partner influence plays an important role in influencing women to smoke nyaope and further transition to injecting. Women are more likely to start using drugs as a result of family issues and the influence of their intimate relationship, whereas men are more likely to be introduced to drugs use through their peer and friendship networks. The findings of the study attest that some women started and consequently became addicted because of following their peer, what their peers are doing. Women who inject drugs are more likely to be an intimate relationship with a partner who inject drugs. The relationship with intimate male partners who also use drugs are complex and lively. Next slide. Curiosity. Women who inject nyaope are not on all occasions inactive in transition from smoking to injecting drugs. Often they have an active role in transition. Some participants reported that transition was their own idea. Participants also highlighted curiosity as the contributing factor which influenced them to inject nyaope. Next slide. Cost effective. Nyaope comes at a high price. The majority of the participants indicate that injecting nyaope produces the cost as one achieved an intense high and remain the body for longer, and it remains in the body for longer. Injecting nyaope reduces the cost of sense that the user uses less to get intense high. Next slide. Discussion. The finding of this study affirm that there are factors that influence women's decision to smoke nyaope and intrathecal injection nyaope. It also shows that nyaope is used by women, and researchers should consider studying women who used nyaope injecting in order to gain better understanding of their experiences. With the increase in women who smoke drugs and women who inject drugs, further delay can increase poor policy making and irrelevant provision of substance use drugs programs. Furthermore, the finding demonstrates that an intimate partner influence play an important role in influencing women to smoke nyaope and further transition to injecting. Women are more likely to start drugs as a result of family issues and the influence of their intimate relationship, whereas men are more likely to be introduced to drugs through their peer and friendship networks. Next slide. Strength and limitation. The strength of this study, the research focused on women who are injecting nyaope. Women who inject nyaope are often overlooked, and they were difficult to recruit to participate in the study as they are hidden and scattered. The sample consists of 24 women participants. The study is the first to this study exclusively women who inject nyaope in the population of South Africa. The limitation of this study are as follows. The study included only participants who were accessing a service in the selected COSAP sites. The researcher employed qualitative research design, and the finding cannot be generalized to all women who inject nyaope. Few studies were conducted within South African context, and UNODC conducted only one study on female nyaope users in South Africa in 2017. The researcher depended on international research for literature. Finally, sample consists of women who inject drug regardless of whether they stay with the family or are homeless, employed, or unemployed. Next slide. Recommendations. Recommendation based on the finding of the research. DACA remains a gateway drug. An intense program on the risk using DACA should be implemented as part of the Department of Education curriculum. Mental health services should be easily accessible. The finding highlights that women use drugs because of lack of effective coping mechanism, which mental health services can address. To prevent blood-borne infection among women who inject drugs, injecting practice must be regulated, monitored, and harm reduction initiative must be implemented. Recommendation based on future research. More studies on women who inject drugs should be conducted to understand better the South African drug injecting context, instead of understanding South African drug injecting context using international research. A follow-up quantitative study on factors contributing to the use of nyaope should be conducted. Next slide. A recommendation based on policy practice. Programs that educate drug injectors on safe injection practice should be funded and upscaled. People who inject drugs are a highly vulnerable group with high statistics of mortality and premature mortality, and they should embrace harm reduction services that can offer support financially. Next slide. I would like to thank my student, Mr. Ifoka, who completed his master's under my supervision. This study was a wake-up call, and the University of Pretoria, that is responsible for managing those COSAP. That is the only organization in all the provinces in South Africa. Thank you very much for listening to me. Thank you.
Family physician who addresses common health problems of the population. Today's subject I am discussing is about what is called as pruritus. Technically is simple itching over the body, any part of the body. As we know, human beings cannot tolerate certain things. They run for medical aid when they find themselves in certain health problems. The commonest being pain any part of the body, bleeding from any part of the body, swelling in any part of our body, and last but not the least, probably the worst one which people would run to seek help is itching, particularly when you are in a group of people. If you start itching, you are so uncomfortable, you will run. My discussion today is, while it touches on the basic issues of itching or pruritus, mostly we talk about how do you save seniors who have a maximum problem of this issue for various reasons. With this introduction, my first slide says, what happens in general practice? If you are a family physician, particularly in developing countries, because still in the rural India, people seek attention from a general practitioner first before seeking to a specialist. So we define itchy skin, which is caused by various factors, basically due to allergies, environmental factors, and there are underlying medical conditions. We categorize itching or pruritus into 7 groups. The commonest being systemic diseases like thyroid, polycythemia vera, etc. There are skin diseases commonly which have the maximum chances of giving itchy skin, known as geriatric, which is a dry skin, irritant or allergic dermatitis, atopic dermatitis, psoriasis, urticaria, and seborrheic dermatitis. There are certain neural conditions we call as neuropathic pruritus. Basically, it is brachioarterial pruritus triggered by ultraviolet rays, brachioradialis, which is a C6 dermatome of the muscle, and notalgia paresthesia is a chronic condition characterized by intense itching, burning, tingling sensation, basically over the back, upper part, around your scapular region. The fourth category is psychogenic pruritus. These are somatoform disorders, dissociative disorders, schizophrenia, hallucination, delusional parasitosis, and adjustment disruption. Fifth category is called as drug-induced. Sometimes you say that if you do not tolerate, you may get rashes and itching. The sixth category, which is also called as multifactorial, it's not one, there are a combination of the above 3, 4, 5 anytime. And last but not the least, and more important for the seniors, since we're talking today more about seniors, is what is called as idiopathic pruritus, where it is difficult to detect the reason and primary rash are absent. Xerosis and other recognizable causes also cannot be identified. Now, based on the practice and age of the people, I have tried to classify the major problems of itching. In childhood, in children, Basically, those are allergic reactions to wool, soap, poison ivy, cosmetic, and certain foods. Most importantly, minor insect bites. Anemia, particularly iron deficiency anemia, chicken pox, skin condition, as already mentioned, dry skin, eczema, etc. Scabies is the most common in poor, underdeveloped countries and poor socioeconomic population, and head and body loss, psoriasis. Hives, systemic diseases like kidney failure, liver disease also cause. Children, leukemia, lymphoma, multiple sclerosis, reactions to drugs, shingles is another thing even in children, thyroid cancer, and type 2 diabetes. If you go to the next generation, that is among the adults, basically it is skin conditions like eczema, psoriasis, contact dermatitis, allergic reactions to basically pollens, certain foods, latex and metals, insect bites, even mosquito bites sometimes cause a lot of itching. Bed bugs are the other in the poor socioeconomic population, and any other insect bite may cause itching. Allergic reaction to drugs, particularly penicillin and antibiotics. The systemic diseases include liver diseases for any reason, hepatitis, cirrhosis, cholestasis. Kidney disease causes itching due to buildup of waste product in the blood. Thyroid disorders, both hyper and hypothyroidism, are known to cause itchy skin. High blood sugar, again, can lead to itching. Anemia, as already told in the children, iron deficiency and causes itching. The other factors in that include xerosis, especially in the dry weather, which increases with age, fungal infection, parasitic infection like scabies. Women during pregnancy, because of the hormonal disruption, may complain of itching, and psychological factors also, which affect more the ladies. Now, coming to the key focus of my discussion is among the elderly. Apart from the standard dermatological causes, as listed earlier, and systemic diseases, again we discussed earlier, environmental factors, basically these are medications, because the elderly person have multiple problems and they would be taking on an average 6 to 10 medicines a day. Neuropathic pruritus, basically if nerve damage occurs either due to diabetes or other conditions. Psychogenic processes, here again, if the elderly person is neglected, is not given due attention by the family members, either anxiety or depression leads to itching. There are age-related diseases like reduced sweat gland activity leading to dry skin, decreased sebum production, stratum corneum gets disrupted and therefore lead to itching. Multimorbidity causes basically is due to combination of multiple conditions these elderly people have. The most important is what is called as senile pruritus, as I told you, where we cannot find any of the listed causes of itches. So here, what is senile pruritus? Basically, it is an elderly people reporting itching as a most common complaint. It is defined as a chronic itch in a person aged over 65 years, where we cannot determine etiology by all appropriate examination and checkup. You do everything, lots of investigation, still you don't find what may be the cause. It is a kind of non-dermatological origin. It means skin is not involved. without any skin lesions, scratching can appear. There are multiple causes, but no cause, quality of life gets greatly reduced for these elderly people. Psychological condition, as discussed already, anxiety, insomnia, depression develop in senile pruritus. Though we cannot find any reason, determining the etiology is the first step to give relief. Knowing very well, often we will not be able to know what the cause is. The final diagnosis, unlike any other condition, comes only after ruling out many other things where you don't have an answer by the physical examination or investigations. So, for patients with fragile health, polypathological and multimorbidity patients, you must rule out dermatological diseases, use of medicines, blood diseases, chronic cancers, chronic liver disease, kidney disease, neuropathies, diabetes, polycystic. You can see how many lists are there which have to be read out before you brand it as senile pruritus. So basically, in one sentence, we say absence of all the known causes, then you diagnose it as senile pruritus. It could be either acute or chronic when it continues for more than 6 weeks. The basic epidemiology of senile pruritus, nearly 1/5 of the population of the senior citizens have this condition, which is maybe ranging from different studies have reported anywhere between 15% to 33%. Based on a meta-analysis of 17 studies across the world, which included about 29,000 participants. The prevalence is influenced by age, sex, and location. The age-related prevention is quoted to be highest rates in the individuals of 80 years and above. The proved prevalence of 12% in those aged 60 to 69, 27% in the people aged 70 to 79, and 51, that is half of the people over the age of 80 years, and more than that if you include those beyond 90 years. In terms of the sex prevalence, males has higher prevalence of around 19% as compared to 8% in the female. That is almost about double. In terms of places, Turkey and China are having much higher prevalence compared to developed countries like Norway, Denmark, Britain, etc. Smoking, particularly excessive smoking, and monophagism were possible risk factors for senile pruritus. The exact cause we already know is not known as of now today. What can aggravate senile pruritus is baths which are taken too hot for too long, unsuitable or poorly rinsed hygiene products like perfumed soap, detergents, antiseptics. Overly aggressive washing. Some people are worried about their cleanliness, keep washing, be it skin, be it their clothes, by excessive rubbing that causes, and using perfumes. Irritating and or tight clothing, particularly jeans which are never washed for months together, or maybe the causes, particularly around the genital area. Scents and overdose laundry detergents, fabric softeners, living conditions that are too hot or too dry in summer, particularly when the temperature goes beyond 35, 37 degrees, and consumption of certain traditional stimulants such as tea, coffee, and alcohol. Now I walk you through 3 cases which we managed very recently to give you an idea. This is not necessarily only senile, but a combination of cases we see before we come to a diagnosis of senile pruritus. One was an elderly lady of 82 years. She was restricted because of the femur fracture on her bed, except for going to toilets with the support of a walker. She started complaining one fine day, itching over the back, thinking that it is due to sleeping for long hours. The positions started changing. Family did what in India people do. We call them as home remedies. Usually they start restricting certain diet like eggplant, sour and salty food, and then also feed them with bitter leaves of nimba, which is called locally in Hindi as neem, and turmeric. That did help for a while, but after a week or 10 days, they were fed up and they took the help of Indian system of medical treatment. People go in India for ISM basically because they are less costlier. And here, the common practice is what is called as pancha karma. Pancha means five things. They use certain things to do. Purgation is number 1, followed by virechana, which is medical herbs, and emesis, that is getting them made to omit certain things. Lepa is applying certain oils and paste over the itching site. The worst practice among them is what is called as rakta moksha, which is nothing but blood letting from some part of the body, which is peripheral usually. This family refused. So this out of the panchakarma, the 4 practices were done. They did give her a relief. After getting relief, they stopped it, and within a week's time, this situation came back to where it was. That is when they approached me. I had to do an examination on video call because this is from a place outside of Bangalore city. What we did is, after examining and ensuring that there are no eruptions anywhere in the body, we put her on oral antihistaminic. Allegra is 180 milligram containing fexofenadine in the morning. Since this lady also had a lot of family problems which worried her all the time, I put her on chlorpromazine 25 milligram at night and topical application of crotamidone 10% lotion to the affected area twice after cleaning the site very well. It is just 3 days after following schedule, she reported improvement, and over a period of 2 weeks, she was doing well. My second case is another lady of 76 years, unable to sleep and was scratching all over the body. This is the mother of my maid servant. The history revealed that this is happening since a month, and they also had tried all their home remedies, like application of coconut oil, which do give baby. And they try, this is another alternative where we have what is a system called as homeopathy system, which takes care of giving certain drugs orally and also local application. Usually, homeopathy system tries sulfur as the first remedy for dry, scaly, unhealthy, burning skin. Being an antiseptic, it has an independent anti-psoriatic action and therefore gives good relief during psoriasis. Then arsenic album was also used, which is used peeled off skin if the skin is peeled off after scratching. Rux, toxic adrenaline, is an agent. Of course, this was not tried. This is another thing which is used in itching with blisters like shingles, herpes zoster, etc., and even scabies. Again, after a month of trial of both home and ISM, they came to standard practice to me. We followed the same thing which was reported in the first case for a better relief. Now, this is the general chronic idiopathic pruritus where we ruled out all possible things to come to a conclusion this was the real senile pruritus. A 68 years old male presented to a medical college hospital. Being a government hospital, the treatments are free in India. And we as public health students, we had taken our call as medico-social case study. They studied possible thing. It was a new onset, diffuse and intense pruritus, gradually progressed over a period of last 2 months. The symptoms began at the lower extremities and advanced to present on the upper extremities as well. The patient had decreased quality of life, irritability, with an inability to work or sleep due to itching. Condition exacerbated by stress due to both grown-up sons disowning him and ultimately getting to this private government hospital for free treatment. The history and physical examination revealed excoriations on both upper and lower limbs, particularly more important on flexor surfaces. There are no specific nodules, but there was post-inflammatory hyperpigmentation. He was treated with anti-inflammatory as we do the standard and cortisone, which did not yield any benefit. Finally, the dermatological expert tried what is called as GABATA, which is gabapentin, and the outcome was complete resolution of symptomology within a week's treatment. So patients with uncontrolled idiopathic pruritus, the trial of low-dose gabapentin is useful and it is commonly practiced after trying the basic antihistaminics, local application, and corticosteroid. So mechanism of this efficacy is still to be understood, but the results are favorable. The pathophysiology, talking of pathophysiology of the things, it's a slow-conducting, unmyelinated, polymodal, potentially type A delta, non-receptive neurons, free nerve endings near the dermato-epidermological junction or in the epidermis cause pruritus. These neurons are more pruritigenic, drug-sensitive than pain receptors. Histamine, neuropeptide substance, serotonin, bradykinin, proteases, endothelin are activators for these nerves. The dorsal root ganglia sends impulses to the thalamus through the spinothalamic tract. Opioids are known to both peripherally and central modify the feelings of pruritus. These receptors increase the pruritus, whereas kappa receptors and mu receptors block and reduce the itching. The term mediator-related pruritus refers to certain mediators such as histamine, 5-hydroxytryptamine, protease, opioid peptides, and eicosanoids, which mediate itching. Then there is renal pruritus is due to high levels of histamine in the patients receiving hemodialysis and patients with chronic renal failure experience this. Cholestatic pruritus is basically again due to venous histamine levels. Endocrinal pruritus, again in hypothyroid, it is linked to vasodilatation, excess thyroid hormone, and pruritus in malignancy is triggered by the release of toxin by the immunosystem. The basic management in what is the understanding in allopathy? In allopathy, we say the International Forum of the Study of Itch has said there are 3 types. One is pruritus on a diseased skin, then pruritus non-diseased skin. Group 3 is pruritus presenting with serious chronic secondary scratch lesion. Based on this, there are 6 categories of pruritus classified: dermatological, systemic, neurological, psychogenic or psychological, mixed, and finally, the pruritus of undetermined origin, which we already discussed. Having the relationship of pruritus to skin aging and neuronal aging or immune aging is still poorly understood. Therefore, there is no precise differentiation as of now. In the absence of any specific cause, a diagnosis of senile pruritus is proposed and made. Now, allopathic, we have already discussed standard treatment. I would not go into that. It basically involves promoting hygiene, encourage to their other habits of taking baths of a short baths, not longer hot, without perfumes, etc. Standard treatment involves emoluments, corticosteroid, lifestyle modification, antidepressant, and in Ayurveda, which is another Indian system medicine, they basically call itching is due to increased pitta or decreased vata. So what do these words mean? In vata, the skin becomes dry, rough, and scaly. And this happens because they say due to consuming dry, cold, or stale food, popcorn, crackers, bitter and astringent foods. Excessive physical activities, irregular sleep patterns, exposure to cold or other triggers to aggravate vata. Basically, the treatment includes oatmeal bath, that is soaking in a warm bath with powdered oatmeal for soothing dry, irritated skin condition. The treatment of itching due to pitta, which they say will be looking like burning red itchiness aggravated by heat, overconsumption of spices, sour fruits, acid foods are the triggers, applying coconut oil, using neem and turmeric paste, and oatmeal bath and aloe vera gel are the treatment. Itching due to kapha, most moist, slow healing itchiness, often accompanied by swelling. Heavy, oily, cold foods aggravate kapha and dairy products. Sweet fruits, processed food rich in sugar. A sedentary lifestyle, daytime sleeping, residing in cold and damp areas lead to kapha. The treatment in kapha-related itching is done by neem and turmeric paste applying locally. And there is what is called as Triphala Churna, which is beneficial in all 3 types of dosha, which the system identifies as the cause of itchiness. The homeopathy system in India looks these pruritus as a symptom, but not as a disease. And they describe it could be either generalized or localized and have been there for a few days or recent origin. The causes according to homeopathy system are skin condition, internal diseases, nerve disorders, almost like an allopathic system. And the treatment approach, as we saw in one of our cases, is use of sulfur, selenium, and arsenicum alba. Drugs, toxicodron, whenever itching is intense, and there is product called as natrium uricatum, has a marked action upon herpetic eruptions. Homeopathic medicines are selected based on the patient-specific symptoms and constitution, aims to correct balance of psychological function of the body and stimulate the natural healing process. With this, I end my presentation. Any questions are welcome. Thank you.
Thank you.
Hi everyone, my name is Muhammad Ali, Specialty Doctor of General Surgery, West Wales in United Kingdom. It's my pleasure today that I present my this presentation with you. Nice to meet you all. This presentation is titled under the name of Robotic Surgery in Pediatrics, Innovation and Future Prospects, which I think it is relevant to our conference, which is the third international webinar on global health and medicine. So I will talk about the innovation or the updates and what is the news. What is the news on the pediatric surgery? Is robotic pediatric in pediatric surgery. So let's start. Let's start with a small introduction on the robotic surgery. As all of us know that robotic surgical interventions provides several benefits compared to traditional methods, which is open method, including greater perception and reduced hazard and superior visualization in tight surgical spaces. Unlike if we compared it to the laparoscopic surgery, the Da Vinci surgical system and newer platform like as enhanced surgical systems now used for various pediatric operations. These systems offer enhanced visualization and accuracy, which are crucial when operating on smaller anatomical structures, like in pediatric age group lateral pediatric age of group. Robotic surgery initially gained traction with prostatectomy in adults. The high cost of robotic system and an instrument specifically designed for children continues to be a barrier to wider use or global use, because these children are very small and they need a specific instrument unlike the adult. Additionally, there is still a lack of extensive clinical data which is supporting a long-term outcome of robotic surgery in pediatric patients. In units, it presents a distinct challenge, including limited operative space. Imagine that there is a challenge in pediatrics, so imagine about the units, which are quite smaller than pediatric age group. Difficulty in trocar placement and an increased risk of instrument collision. The methodology, it was a narrative review of robotic pediatric surgery from 2016 to 2025, almost 10 years. Database searched using a keyword of on outcome, cost, artificial intelligence, and learning curves. Included only peer-reviewed articles focused on pediatric robotic surgery, and this narrative review was published in PubMed Index Journal in the beginning of this year. So let's start. I will give you about first an overview on the robotic surgery in pediatrics. Robotic surgery for adults began in the mid of 1980s. The first documented pediatric robotic procedure was conducted in 2001 when a girl who had a robotic Nissen fundoplication. This is the first date of robotic surgery in pediatrics. Recent studies indicate that the robotic surgeries in children have comparable outcomes with traditional laparoscopic method, while offering benefit such as shorter hospital stay and reduced complication. So let's start with examples about the usage of robots in pediatric surgery. For example, first, robotic diaphragmatic hernia repair. A case report demonstrating a successful use of robotic surgery for delayed traumatic diaphragmatic hernia was reported. Another study on Morgagni hernia repair described robotic trans-abdominal peritoneal technique. While robotic diaphragmatic hernia repair offer a significant advanced and and another advantage like visualization, access, and texture. There is also a limitation, which is high cost and specialized care requirement. To be honest with you, this disadvantage and advantage will be the same, more or less in all of the examples that we are going to discuss with you now. So let's go for another example for the use of robotics in pediatrics, which is congenital esophageal atresia repair. Esophageal atresia is a birth defect where the esophagus is discontinuous, preventing the connection between its parts. The first case of robotic thoracoscopic esophageal anastomosis was done first in China, demonstrating the feasibility of this approach. The patient mean weight was 3.2 kilogram, and the operative time was about 2 hours. Roughly we can say 95 minutes, with anastomotic time being 27 minutes. Several reported cases of successful robotic repair of esophageal atresia then conducted later on. However, the risk of esophageal fistula recurrence remain a challenge, and there is a need of a specialized training surgeon again. Let's move to another example, which is the colorectal surgery in pediatric age groups. Robotic surgery is gaining recognition as a safe approach for treating pediatric Hershey-Sprung disease. This procedure typically involves using these 3 robotic arms and the additional 5 mm trocar. The learning curve for robotic surgery in Hershey-Sprung disease seems shorter than that for open or laparoscopic technique, yet achieving optimal results still required again a skilled surgical team and tailored procedure adjustment. Okay, and let's move to another example, which is pulmonary lobectomy. Congenital pulmonary airway malformation and intralobar pulmonary sequestration are pediatric thoracic surgeries, most commonly disease. Lobectomy is a standard surgical approach for this condition. Robotic lobectomy has been started while acceptance first, and the first procedure was done in 2003 in an adult patient in the United States. The study found robotic surgery is a safe and feasible option for patients over 6 months old, and improve surgical efficiency and comfort through advanced ergonomics and 3D visualization. This is for pulmonary lobectomy. Okay, and now let's talk about the usage of robot in the urological surgeries, which is a lot, for to be honest with you. For example, physico-ureteric reflux increases the incidence of urinary tract infection and renal scarring. Diagnosis is challenging, especially in infant, due to non-specific symptoms. Robot-assisted ureteric reimplantation for physico-ureteric reflux offers several benefits, including enhanced visualizations through 3D imaging again, and dexterity and tactile sensation, reduce the post-operative pain and shorter hospital stays, typically lasting 1 or 2 days. Another example, which is ureteropelvic junction obstruction. Robot-assisted pyeloplasty has emerged as a gold standard for treating pediatric ureteropelvic junction obstruction, offering shorter operative times and success rate comparable to laparoscopy. Also, robotic in bladder reconstruction over the past few years, robotic bladder neck reconstruction has been started to be increased in the usage or the number of the cases and documented in the literature. However, the outcome are comparable to those of open surgery are still low. At the same time, incontinence rates appear to be lower. However, further prospective studies with extended follow-up period must validate this result. We need a lot of a lot of research in this field specifically. This diagram showing the usage of robot, especially in urological surgery, which is robotic ureteral implantation, robotic bilioplasty, and robotic bladder reconstruction. The robotic bladder reconstruction, it is comparable to outcome with to open surgery with better incontinence rates, though more study needed. Robotic bilioplasty, gold standard for for the UBG, which is uretropelvic junction obstruction, with short operative time and high success rate. In the robotic ureteral implantation offered enhanced visualization, reduced pain, and a high success rate for vesico-ureteric reflux. Now let's talk about the usage of robot in the oncological surgeries, like particularly in neuroblastoma, Wilms tumor. While open surgery remains a gold standard, robotic techniques offer potential benefit over the open surgery. A successful robotic resection of stage 4 neuroblastoma has been documented, with the author attributing the positive outcome to the enhanced visualization and the perception of robotic system providers. In stage 4 neuroblastoma, that means that the disease is too advanced and attached to the surrounding vessels like the IVC, the aorta. So it needs a skillful surgeon and a lot of dissection, and it is hard to be done in open surgery. So imagine it with the robotic surgery. Some concerns have been raised about the use of robotic surgery in children, specifically regarding the adherence to fundamental oncological principles, achieving clear section margin, and preventing tumor spillage. One theory suggests that the lack of haptic feedback in robotic procedure may hinder the surgeon's ability to distinguish between cancerous and healthy tissue, because robotic like laparoscopy, we can't use our tactile sensation or our finger to differentiate between the cancerous and the non-cancerous tissue. And also there are also another example of robotic resection, which is in oncological, like robotic adrenalectomy, which is emerging as a minimally invasive alternative to pediatric adrenal tumor, with high tumor resection with laparoscopy, with a high success rate nowadays. Here is the diagram showing the advantage and disadvantage of usage of robot in pediatric oncology surgery. Advantage like enhanced visualization and precision in this section, improved ergonomics and minimal invasive and shorter recovery, shorter hospital stay. Disadvantage like of tactile sensation, haptic sensation. It's the same in the laparoscopy. Concerns about resection margin, also, as again it is the same as the laparoscopy, but I think with the advanced pathological procedures and and also advanced investigation, it shouldn't be a disadvantage nowadays. Potential tumor spillage, it is written in the literature, and it needs more research regarding this point. High technical demands, and also because you need a set of robot and will equip the theater room and staff and a lot of, and also the technician to operate on it, or to manage to and also limited cases study. Still, we need a lot of research in this field. Now, as you see, the main disadvantage of robotic surgery is the lack of skilled it needs, or another word, it needs a skilled surgeon. So what about the training and the learning curve in robotic surgery? Surgeons should receive simulation training before starting robotic pediatric surgery or even adult robotic surgery, like any when they start also open surgery or even laparoscopic surgery. But here in the robotic field, they lead an structured training program that combines didactic courses hands-on training and supervised operating room experience to enhance learning. Also, mentorship is critical. There are structured programs like SAGS and FRCS which reduce the learning curve, but still it needs more progress in this area. Challenges and the limitation of robotic surgery. One of the most pressing issues in robotic surgery is a mismatch between the size of robotic instrument, as we said before. We are talking about challenges and the limitation specifically in the pediatric age group, which is the size of an instrument. Mismatch between the size of an instrument and the small working space of children. The Finchi surgical system, a commonly used robotic platform, recommends a 6 cm distance between boards, which is often unachievable in a pediatric patient due to their smaller body size. The current robotic instrument typically 5 millimeter or 8 millimeter in diameter and often too large. Traditional laparoscopic instrument used in pediatric surgery can be as small as 3 millimeter, highlighting the need for smaller robotic tools specifically designed for neonatal use. The lack of commercially available 3 millimeter robotics instruments significantly limits the application of robotic surgery in children and very young infants. Robotic surgery faces challenges in neonates, especially those under 3 kilograms, due to the large size of an instrument and the limited working space. And also, we need to highly specialize, highly trained surgeons. This constraint can cause robotic arm collisions, reducing precision and increasing risk of complications, sometimes requiring conversion to open surgery. I collected, or I managed to put all these challenges in one slide, as we said, technical challenges, issue with an instrument size and the size of neonates or size of the pediatric age group. Cost and accessibility, a high cost and limited availability of robotic system in pediatric care. Accountability and legal liability, complexities in determining responsibility for surgical outcome, it is another issue. Ethical consideration, balancing technology use with patient safety and parental autonomy, because when you discuss the technical or surgical steps with the parent, it is another issue that how to convince the parents that we are going to do this surgery through robot, and it will take too long time, and it is still needs a skilled surgeons and a lot of this stuff, and they accept it at the end. So it is an ethical consideration. We can say, or we can put ethical consideration and accountability and legal liability together regarding the challenges. Now, future perspectives and the conclusion. New robotic system like Senile surgical robotic system offer better maneuverability, individual robotic arm and magnet-based instrument attachment for quicker magnet. They use magnet instrument-based instrument attachment for quicker interoperative exchange and compatibility with a smaller port. So this is the advantage of enhanced robotic system over the Da Vinci or the older robotic systems. Robotic surgery is safe and feasible and likely to expand in beyond pediatrics. So it is a progressing field. See this field or see or read the literature after 10 years about the usage of robotic surgery, and you will be surprised about the results. Requires further data and equitable access and to become standards. And I think that's it. Yeah. Thank you for listening for me. Thank you all. Nice to meet you.
I am currently the head of oncology at Clinic Ascons here in Santiago, Chile, and also a public hospital here at Santiago, Chile. So I'll proceed to share my presentation. Basically, cancer is the first cause of death in Chile, with approximately 30,000 deaths per year. As every other big country in the world, also lung cancer is a huge issue in our country and is the first cause of death of cancer. We do have a mixed health system, which consists of a public and a private health system, basically, but 90% of the population is based on the public health system. So this comes with a lot of issues in terms of access to drugs and molecular testing, which is a current limitation for our patients in terms of the timing in which patients can access to a proper diagnosis. And in cancer, we know that time is really important to be able to diagnose an early stage to offer more curative treatments. And cancer has been a transformation in terms of knowing more and more different aspects of this disease in order to personalize treatments and individualize treatments. That's the key to overcome the better overall survival with better quality of life, which are the two most important aspects in order to deliver a proper treatment to our patients. And lung cancer has converted between two huge big groups, which we used to know in the 90s, to have different subgroups in which we personalize treatment. We have 10 patients with lung cancer. Most probably those 10 patients are going to be treated differently as of today. And as I was mentioning before, it has transformed from two big groups in histology, like adenocarcinoma and squamous, to have different biomarkers which help us to predict the response to different treatments, like could be immunotherapy. As you could see in the slide, there are many biomarkers like tumor mutational burden and PD-L1, which help us individualize the treatment in order to select better treatments. And once we select better treatments, we might have better response in our patients. And this has not only been in lung cancer, but we also have seen it in other type of cancer like colorectal, melanoma, endometrial, which provides us more information of our patient. And we should have this information in every single patient before we start a specific treatment. Just to show you, this shows the broad spectrum of targeted mutations we have in lung cancer, but it would not be possible to have a target mutation or driver mutation if we don't have a target treatment. But nowadays, once we have the driver mutation, we have access to targeted treatments. Basically, in lung cancer in stage 4, 50% of our patients are going to have a target or driver mutation. And once we have the information of the driver mutation, we can select a target treatment. Like, for example, for EGFR sensitizing mutation, we have treatments like osimertinib. For ILK, we have lorlatinib. So it's very important to know this information. But to access this information, we need a lot of a process which works perfectly fine. And this probably is the huge limitation in most of our countries all over the world. Because in order to get this information, we first need biopsy. But the biopsy has to fulfill certain requirements in order to be able to be processed, to be able to have this information. So once we have a biopsy, for example, a fine needle aspiration or exophageal cytology would not fulfill exactly with the blocks in order to be able to get this information. We do need either resection, excision, or small tissue biopsies. And once we have this information, there are different ways to get this information. So basically, in countries like Chile or any other countries in Latin America or many other countries worldwide, what we do is that we start studying this targeted mutations one by one. So imagine you have to do first EGFR, then ALK, then MET, then HER2, but your slide of your block will not be able to provide the enough amount of quantity of tissue to be able to do this one by one. So you have to do amplifications by panels. And there is where PCR appears or NGS appears, which are the broad amount of test tools that we have nowadays worldwide to be able to get this information. And that's not only done on DNA. Nowadays, we know that we have to measure in DNA and RNA because we know that by measuring in DNA, there are certain detected fusions that may not be expressed or detected. And if we study them in RNA, we can have that information. And most importantly, once we have DNA and RNA, the effect, the clinical benefit of that patient treated with a targeted therapy to the mutation driver is approximately of an 80%. So the probability of having a treatment which is effective for controlling your stage 4 lung cancer, if you have a targeted treatment, is very, very high. And this has to be processed throughout the world because this needs education in all the clinical teams, not only in certain countries, but it has to be a national policy for the patients to have this information and for the oncologists to have this information as soon as the patient is in the first clinical when he comes to the clinic, right? Because having this information beforehand will help you to select the best treatment. And as I was mentioning before, 50% of the patients will have a driver mutation, which is candidate for targeted therapy. Not only it helps us to get treatment, but it helps us to know our population. This is a trial we made in which we measured a specific mutation called HRAS, a G12C, and we can see that it has there is an heterogeneity not only in the same continent, but also in the same country. In certain areas, you have a higher incidence of this mutation versus other areas of the same countries in which the incidence is low. And that's because of the risk factors as you have the air density, the smoke, the amount of risk factor as smoking, and also other like arsenic and other risk factors that we know in lung cancer. So basically, HRAS is one of the most common mutations in lung cancer, and we have to know this information also, and now we have a targeted treatment. Now, the barriers to universal testings basically are communication, because this needs a whole communication of all the teams, since the surgeon, the pathologist, the oncologist. It's very important if you can do a broad panel of NGS to know which testing you have to do at the beginning. Acquirement of tissue. Remember that we need a proper amount of tissue to be able to get the most amount of information. Of course, the reimbursement and the payment and the turnaround time. Usually when the patient knows they have cancer, they want to start treatment right away. So how much the turnaround time will help you to be able, and how to explain to a patient that this information is really important before starting a treatment which could provoke adverse effects and no potential clinical benefit. But what we know nowadays worldwide is that the racial disparities, of course, to accessing NGS and PCR, the rates of biomarker testings are low in several parts of the world, like Asia and America, and the Mid-Central and South America, and Africa also. The rates of NGS testing is significantly lower in Black versus white patients. The rates of targeted therapy is also lower in certain groups, and the rates of clinical trial participation is also lower in certain groups worldwide. So it's very important that we work together to be able to overcome these barriers worldwide, right? It also helps us to know the mechanism of resistance, how I mentioned before. We can also know when a patient is receiving a treatment and the treatment is not working anymore, which is the resistance biomarker which is providing this resistance in this patient. And like that, we can target treatment once again. This was a study we did in PCR also with the mechanism of resistance of osimertinib, which is an EGFR treatment. And how, as you can see there, we have different types of resistance to the treatments. This can help us to retarget our treatment in our patient, and this is also where liquid biopsy enters. We also have treatments, resistance mutations for immunotherapy, which we have developed also in Latin America, for example, STK11 and KEAP1, which are certain specifics of the biopsy, which could help us to know which patients could respond better or have a worse prognosis with immunotherapy. Also, as more complicated treatments we have, more complicated resistance mechanisms the cancer develops. So it's very important to have this information once the patient doesn't continue responding to the first treatment we have developed. And this has been studied. We have a cost benefit, different clinical trials all over the world, which has provided that effectively there is a benefit in quality adjusted life years with the qualities all over the world, providing NGS as a, but as we mentioned before, there are barriers to the biomarker testing. It's there where idylla platform becomes a very good fully automated real-time PCR molecular testing system designed to offer this molecular biomarker results in only 3 hours. It's accessible and it makes molecular testing easy, fast, and suitable for any laboratory worldwide. The amount of sample preparation is easy. The PCR amplification detection are provided in a single cartridge system and loading into the idylla system. And this depends on how the team is comfortable, but once they have developed this technology, this makes it easy for patients to be able to get the information and for the oncologist to have this information in the first clinic as soon we can start the treatment. There are different cartridges which provides different platforms according to the disease. There is for colorectal, there is for lung, there is for agnostic treatment, and there is for melanoma also. This depending on the mutation, which is more frequent. For example, the gene fusion could help in lung cancer. The NRAS BRAF helps with colorectal cancer. BRAF helps with melanoma, and KRAS helps for lung and colorectal cancer and also other solid tumors. So this is we just published the recommendations of how we could use idylla in a country like Chile, which has all the barriers that we have mentioned before. And very important to know the rapid time turnover. This slide demonstrates that the more time the patient takes or the medical oncologist takes to have the information of molecular testing, the worse the overall survivals in lung cancer and colorectal cancer. So this study published also JAMA and also there's another studies published in the Lancet have demonstrated that the turnover has to be the less possible. How much time? Usually between 10 to 14 days would be the perfect timing in order to select the best treatment and would not affect the overall survival. Because you have to think once you have this testing, you have to access to the drug. The access to the drug is also not immediately because it's high cost drug, which takes the hospital or the clinics takes time to be able to deliver it to the patient. So idylla EGFR this is another study was incorporated as a screening method before NGS, which is the most broad type of access diagnosis which different clinics use. But what we want to show here is the concordance of idylla with NGS was 98.62%. So basically 9.8 patients of 10 would have access to their target treatment according to their molecular testing. We have also developed, and we want to know how much is the expression of EGFR, ALK in different populations, especially in Latin America. There's another study within Mexico, Colombia, and Chile. And we can see here that we have like approximately 10%, between 10 to 15% of EGFR in Latin America, and between 7 to 9% of ALK. So basically, this is our method of how we could approximate patients with idylla. Once we have the diagnosis of adenocarcinoma, this patient goes to molecular testing. If they have an EGFR mutation, we go to a target therapy, like would be osimertinib, or if they have an ALK ROS1 MET NTR-CAR or RET, we go to another direct mutation. That patient doesn't have to go to chemotherapy. That patient goes to an oral treatment. So this particular study gives you so much information in terms of resistance of the target treatment and for getting better overall survival with better quality of life. Remember, these treatments are oral treatments. They don't have the adverse effects of chemotherapy. They do have another adverse effects, but we have learned how to manage them and to make it safe for our patients. The same thing with colorectal. in terms of KRAS, we know if you have a KRAS mutation, the patient should receive anti-angiogenic drugs like bevacizumab, and in case they don't have the KRAS mutation, they could receive medications versus EGFR like cetuximab or panitumumab. The same with also breast cancer. We have a target therapy versus PI3K, which is a resistant mutation we see in hormone receptor patients. And we have a certain combination called alpelisib with fulvestrant, which has demonstrated good control in those patients. We also have agnostic treatment. What does agnostic treatment mean? Nowadays, oncology has transformed into personalized treatment. That means that no matter the organ in which the tumor was born, but there are certain agnostic mutations or mutations which are in all tumors. They're less frequent, but once you have them, you have a treatment which is an agnostic treatment. For example, NTRK, which is a fusion, are activating unpredictable response, and we have a target for cancer therapy, and this can be detected by the idylla platform. How as mentioned before, it's not so frequent, but we do have more frequency in RNA, so it's very important that testing should be done in DNA and RNA to have the most amount of information, and PCR is able to identify the fusion partners, which helps us to give treatments. This is TRK inhibitors, which have an overall response rate of 61%. And this slide shows that it's transversal to different types of tumors like breast, gynecology, cholangiocarcinoma, biliary, colorectal, and lung. This is growing a lot. We have each time more agnostic treatment. Not, as I mentioned before, one example was NTRK, but we have microsatellite instability, tumor mutational burden, FGFR, HER2. So there are a lot of agnostic treatments going on, and KRAS is also one of the most likely to fail. So take-home messages: idylla allows an impeccable method to diagnose driver mutation with a fast turnaround time. Remember, 3 to 5 hours to start target therapy. It also helps us to have local data and mechanism of resistance, and it's cost-effective for our patients. This is very important because nowadays oncology is still evolving. These are all the clinical trials that are ongoing on lung cancer in the last couple of years. So we'll have more treatments, but as we have more treatments, it's our responsibility to select better our patients in order to give them the best treatment and not provide adverse effects without good effective treatment, which could provide good overall survival. So personalized treatment is key to be able to have this good results in overall survival and good quality of life, which is the two most important factors to consider for our patients. So with that, I finish. I will thanks again, once again, the organization of the committee of this conference for having us, and my email is there in case you just have any questions. Thanks so much.
Thank you so much, Doctor. That was an amazing presentation.
Introduction. So in healthcare is a changing landscape. So things are changing on a day-to-day basis, and it's moving very fast. So with that environment, making the right decisions in terms of where the health system should be making strategic investments is a critical component. And why is it so important? There are a few different things. So it helps us to prioritize how limited resources are allocated across different services and infrastructure, because in a health system, small or large, regardless of the size and nature of the healthcare organizations, we are always dealing with a portfolio of different programs and services where we need to make decisions in terms of investments. Influence the adoption and integration of new medical technologies that, as we all know, we are living in the age of AI and analytics and robotics and all of that. So making the right decisions in terms of investing on the right technology is super critical. And then supporting the expansion and development of high impact clinical programs. So for every health system, there is a strategic plan. There are identified priorities in terms of what programs they want to grow, and making the right investment in those targeted services is critical. And then finally, rising healthcare demands and financial constraints as the global cost of healthcare for labor, materials, medical equipment, everything is on the rise all the time. So making making those decisions in terms of what really matters for our system is critical. Now, there are four major factors that influence the decision-making process when it comes to healthcare investment: the hospital ownership, market forces, technology, and finances. So we'll spend some time on each of them. Hospital ownership and reimbursement, especially in the US healthcare, there are broadly two categories of healthcare systems. Most of the major health systems are nonprofit, which are more focused on the community needs, primary care. There is a major focus on mental health and behavioral health at this point. So the nonprofit organizations are heavily driven by their mission, vision, and community development. Whereas, as the name, as we can all imagine, for-profit hospitals, it's the other way around. So they make a very calculated decisions in terms of where there are clear financial ROI or return on investment, and the services, whether they're market competitive and they can help them to give back to the shareholders. Then the second factor, the influencing factor, is market and demographics. At a very macro level, I tried to highlight a few different key trends in the healthcare landscape. Increase in aging populations. So there is an increasing need for chronic disease management, elderly care or geriatric services, and long-term care facilities such as SNFs, the nursing facilities and things of that nature. Enhanced access to primary care. There is a growing shift in the market to move inpatient services to outpatient landscape as much as possible. So that's really a big patient satisfier in terms of patient experience, and it also helps to save money for the health systems. As I mentioned, there is a big focus on behavioral health as well across the board. And then growing collaboration between hospitals, community health organizations, payers, technology firms, all of these different players who have some stake in the healthcare industry, they're coming together to build strategic partnership and manage the end-to-end care continuum for the patients. Technology plays a major role, as we can all imagine. We are living in the age of AI, electronic health records, telemedicine, remote monitoring for patients, and whatnot. So evaluating from a holistic perspective, each of those digital platforms and innovations in a more comprehensive way from clinical, operational, and financial perspective, and making the right decision in terms of which technology really makes sense for our health system is fundamental to before we make any kind of investments on technology. And then finally, financial health and liquidity. So every health system does, at least in the US market, the health system have their CFO, they have their own revenue officers, whose primary job is to manage the operating and capital budget. So building a long-range, what we call LRFP, a long-range financial plan is critical. So we have line of sight to what our strategic goals as a major healthcare organization in terms of 5, 10, 15 years down the line. And that really, the organizations that have more liquidity in terms of finances, who are more cash heavy, they obviously have more leverage in terms of making those long-term infrastructure development type of decisions versus smaller scale rural independent hospitals. They have to balance between their short-term operating budget and long-term strategic goals or strategic financial plan, because they need to manage their short-term needs first before they can start investing on the long-term goals. Now we'll spend some time on different frameworks to evaluate these investment decisions. Most of them are evidence-based. So what we mean by evidence-based design is essentially there are certain frameworks that have been time proven, meaning which really work for major health systems across the world. And they provided great returns in terms of quality, cost, and patient access. For example, how do we improve hospital-acquired infection rates? How do you reduce that? What are the key measures we can take in terms of patient safety and quality? So for those type of decisions, we typically need to do a life cycle cost analysis and determine the long-term operational and clinical needs before we make those decisions. And doing that literature survey, doing the competitive benchmarking, industry benchmarking against comparable other health systems, that's where evidence-based design comes into the picture. The next one is program budgeting. So these are different models of making investment decisions. Program budgeting is essentially when we have a portfolio of different programs, we need to go through certain level of cost benefit analysis for each of those, find out the incremental margin, and then based on those financial and clinical versus patient quality and patient experience type of factors, taking all of that into account, sometimes we do a ranking for a portfolio of programs. And that really helps us to identify which programs may need disinvestment or shifting fund from one program to the other. So we can build a more profitable or more patient-centered program portfolio as a net result. Then the health technology assessment, evaluating different innovations is a different type of analysis, especially with things like whether we invest in Epic versus Cerner, which are the two different models of electronic health records. That type of decisions need to go through a comprehensive analysis that takes into account not only the functional or non-functional technological needs, but also clinical, economic, ethical, regulatory, all of those factors need to be taken into account. And then it's a multi-pronged approach where we need to build a cohesive multi-stakeholder engagement so we can make consenting decisions before we go ahead with any kind of technological investments. MCDA, this is a multi-criteria decision analysis, and we do this all the time especially for large-scale decision-making. If say, for example, we want to create a new bed tower or a new cancer center. So that type of mega projects, we need to really identify what are our guiding principles, what really drives to make those decisions, and then create an investment selection criteria based on multiple factors like cost, effectiveness, operational efficiency, social determinants of health. So it's more of a philosophy of creating a multifaceted weighted criteria, and then you map out different options for that long-term strategic need to build a holistic model and figure out what really makes sense for the next step. Cost benefit analysis, this is fundamental to most of the other frameworks that I just talked about. This is more of the financial part of it, where we need to do the net present value analysis, identify the internal rate of return, and purely based on that financial sensitivity analysis, we make the go, no-go decision in terms of the finances of the project. And then finally, predictive modeling with AI and all of the analytics and tools related to that available in the market. It really more effective in today's world to do a comprehensive, say, for example, forecast demand for our patient needs and then enhancing workflows. So there are different areas where predictive modeling really comes handy. And that really helps us to evaluate the clinical and operational part of the analysis. And then we couple it with things like cost benefit tool and make a holistic decision. Now, what are the key areas where these investment frameworks are utilized? So there are a couple of different things. Infrastructure upgrades is a big one, followed by healthcare technology, as I just talked about, specialized programs where we are identifying what are the programs that we want to grow as a health system, and then crisis preparedness. From infrastructure perspective, when a health system builds their strategic plan for 5, 10, 15 years, we identify what are the infrastructure and new facility needs. And then based on some of those frameworks that we just went through, there needs to be a comprehensive analysis of how do we go about funding those initiatives, what are the clinical and operational needs, who would be the key stakeholders, and then go from there in terms of planning, design, development, and operations implementation of a new infrastructure. The other part of it is there are a lot of outdated infrastructure or healthcare facilities in the US market right now. So how do we utilize things like smart building technologies or AI-driven tools and techniques to upgrade our existing infrastructure and physical footprint? So it's a balancing work in terms of utilizing the limited resources and spaces that we have to make the right investment decisions in terms of infrastructure and strategic growth. Adoption of healthcare innovations, we talked about it a couple of times, but essentially this goes back to what are the key factors that need to be taken into account while making decisions in terms of cutting edge technologies like AI, EHR, telemedicine, and so forth. The challenges associated with that are, as we can all imagine, cybersecurity is a big one. How do we protect our health systems from security fraud or malware and things like that? That the staff, the physicians, the support services, the clinical operations, they all need to be trained on this new technology, which in my personal experience, it's a massive task. And then making sure whatever new technology that we are bringing on board, it's interoperable with our existing systems, meaning it's compatible with the way the healthcare organization works in today's world. Investing in specialized clinical programs as part of the strategic planning process, we need to identify what are the key areas where we need to focus in terms of growth. It's both of an internal analysis versus identifying where the market is heading to. For example, mental health, geriatrics, pediatrics, cancer, and oncology services, those are some of the big ones. And then we need to, when we make investment decisions, especially the long-term ones, those specialized clinical programs need to be taken into account, and we need a strategic plan to develop them. Crisis resource allocation. COVID-19 was an eye-opener for most of the health systems. And since then, I have seen healthcare organizations being more focused in terms of building resilient systems that depend on evidence-based and more analytic focused investment strategies. So we can be prepared for our next disaster in terms, it could be a climate disaster, it could be a virus, it could be cyber attacks or whatever, it could be in different forms, but that preparedness, resilience, and flexibility needs to be built into the system, and investment decisions need to be made based on those factors. Now, key challenges, historical allocation and limitations associated with that, budgetary constraints, and stakeholder misalignment. So I will get into each of those briefly. Historical and ad hoc allocation practices. When we talk about strategic planning and growing certain clinical services, one of the key challenges that we face is how do we accurately project our patient volumes, our needs, and make plans in terms of infrastructure development accordingly. It's sometimes we just go by historical trends, but in today's world, it's not enough. We need to, as a health system, as the leaders of a healthcare organization, we need to take into account different factors, like what's really working in the market, where the demographic shift is happening, where how our peer organizations like health insurance companies are playing a role in this market, which services will be more reimbursed in or more profitable in terms of the reimbursement. So all of those factors need to be taken into account while we are projecting our infrastructure needs and accordingly translate that into our budgetary budget planning for the health system. Economic pressure, there is always a shrinking margin, especially with the global economy and the rising cost of everything associated to healthcare. The hospitals and the health systems are always in budget crunch. So how do you balance between those operating cost, shrinking operating margin, and then make space for your long range financial plan? That's the balancing mechanism that all the health systems are constantly working on. And some of the solutions, as you can see, they're doing the right level of NPV analysis, doing the sensitivity analysis, utilizing private partnership to tap into external funding opportunities. So those are some of the measures how major healthcare organizations are trying to address some of that economic pressure. And then finally, stakeholder and policy misalignment. For any kind of investment decisions, one of the key challenges is bringing on board all the right people. So understanding who are the key decision makers and then who are the influencers from the clinical, administrative, and support service perspective. They all need to be in the same room, go through the analysis, and then make a consensus decision in terms of those strategic fund allocation or budget or the financial investment, because otherwise you get resistance down the line from different groups of stakeholders. There are conflicting priorities and things, and those stuff can really become big bottlenecks to move forward. Future directions, predictive analytics and AI is a big one. So that's really helping us not only in terms of patient care, but also managing some of the back-end operations, streamlining our workflows from clinical operations perspective, staffing, resource management, and all of that. And all of that play a major role in terms of making those investment decisions. Stakeholder-centric investment approaches, as I just mentioned, making sure we have consensus across the key stakeholders is super important. And then we also, more and more, the industry is shifting toward a patient-centric model. We need to understand the patient journey from the time when a patient comes to our doorstep as a healthcare organization, all the way through the treatment, discharge, and even the post-acute care. And making sure that whatever decisions the organization is making, the patients are at the front and center of those models. And then finally, sustainability and long-term value. There is a lot of focus globally right now in terms of environmental, social, and governance goals. How do we make investment decisions that really support our sustainability goals, like net zero energy or reducing the carbon footprint? So some of those factors also need to be considered while making these investment decisions. So to summarize everything, aligning investments with strategic goals, that's the number one step. As a healthcare organization, we need to have a defined strategic goals and strategic plans, and then drill it down into different tactics. And that should be the guiding force to evaluate our investment options, followed by different frameworks, the evidence-based frameworks that I just described, to evaluate or assess some of the options. Balancing financial discipline with patient-centered outcomes, that's the crux of the whole analysis. How do we take into account clinical, financial, and patient access and all of those other factors in a cohesive manner, and do a really good job in terms of comprehensive and holistic analysis before we make the decisions. Using predictive analytics and scenario planning is sort of an enabler with all of the cutting edge technologies that we have. engaging the right stakeholders, and then planning for sustainability and resilience for any disaster planning. So these are some of the fundamental or key elements that need to be addressed to some extent based on the nature and size of the healthcare organization before they make strategic decisions to grow their clinical programs. So with that, I think that's the end of my presentation. If there is any question or concern, please feel free to reach out to my email address, bishan.nandi07@gmail.com. Thank you.
Thank you so much, Doctor. That was an amazing presentation. If anyone has any questions, they could reach out to his email or they can.
Examples of these problems include domestic abuse, avoidable enmities, some mental illnesses, crimes, wars, genocide, and others. Attaining benevolent mindfulness is a key result of any process leading to mature, healthy character development. At the same time, avoidance of insults that lead to selfish, malevolent behaviors is critical if human potential is to be optimized. This paper is meant to provide a roadmap to the process of fostering child development so that virtuous helping behaviors are the rule and vices actively avoided. Now, experts generally agree that authoritative parenting is critical to the healthy mental development of children. With this type of parenting, confrontation with responsiveness characterizes the approach to discipline. Confrontation involves identifying and counseling regarding misbehavior. At the same time, recognition and management of stress associated with misbehavior and certain life events is regularly attended to in order to prevent long-lasting adverse mental sequelae. Shaming, coercion, intimidation, and corporal punishment are not utilized as they are in authoritarian parenting. This is to avoid the toxic stress that is the product of preventable adverse childhood experiences. With authoritative parenting, the communication set up between parent and child leads to healthy interpersonal attunement that serves developmental progress. Unfortunately, authoritarian parenting often is passed from generation to generation. Adverse sequelae, including mental illness and violent behaviors, are often seen. For this reason, an active effort to break the cycle of authoritarian parenting and teach authoritative parenting is vital. This effort may start while couples are attending prenatal education classes. In societies where authoritative parenting is not the rule, a child development team may be organized to promote desirable parenting practices. Lastly, permissive and uninvolved parenting also need to be avoided due to the lack of direction for desired behaviors associated with these parenting types. Now, with authoritative parenting, reciprocal communication between parent and child is established in the newborn. This begins with en face or eye-to-eye contact, especially during feedings. Later, it may involve reciprocal smiling, singing, talking lovingly to the infant, and play activities before elementary communication with language is possible. The interpersonal attunement that develops describes how caretaker and child are responsive to one another's emotional needs, thoughts, and moods. When well developed, this interpersonal neurobiology involves a resonance where the thoughts, needs, and feelings of the other are regularly appreciated. Appropriate responses are often the result of such attunement and lead to the strengthening of the bond between caretaker and child. Now, imprinting describes a situation where a young animal comes to recognize another animal, person, or thing as a parent or other object of habitual trust, often shortly after birth. In humans, we usually use the term attachment to describe the trusting relationship that develops between child and caregiver. This trusting relationship strengthens over a period of months to years due to ongoing interpersonal attunement with caregivers being responsive to the child's needs. In order for attachment to be successful, an initial bonding of love and tenderness the caregiver feels for the infant needs to occur. As Andrea Hollingsworth has stated, over time, secure, attuned attachments with other persons may enable us to love more and fear less, rendering us progressively more capable of sharing in the suffering of others and increasing the likelihood that we will take action to alleviate their misery. It is these secure attachments that allow caregivers, teachers, and mentors to influence the child developing mindfulness or intrapersonal attunement. Now, intrapersonal attunement or mindfulness involves noticing and respecting oneself. It refers to a self-regulation of attention where one pays attention to the events of the moment. This process requires an orientation to learn values represented in cortical areas of the brain. Intrapersonal attunement enhances the capacity for emotional empathy. If certain values related to a particular circumstance are internalized, it is clearly necessary to provide a moral learning process that will enhance emotional empathy and serve as the impetus for helping behaviors. Developing a moral compass should insulate persons from blindly following a group who are caught up in inadvisable behaviors. Thus, moral learning should provide protection from de-individuation, so characteristic of authoritarian societies. Now, moral learning can be transmitted in a number of ways. Basically, the exercises involve either classical or operant conditioning. Every effort should be made to eliminate the corporal punishment and shaming that are commonly used by some, quote, educators in certain situations. Such reinforcement often results in repressed fear and anger that serve as a well of energy waiting to be discharged on targets that may be established by false narratives. Moral learning is taught by either dilemma ethics or plain moral facts, with several vehicles commonly used for such teaching. These vehicles include the modeling of caring behaviors, reading stories with a moral, and human relations programs for children. Moral decision-making that results from such learning becomes emotional, intuitive, and automatic when dealing with a familiar issue. Alternatively, decision-making may involve conscious, controlled reasoning based on prior or new learning when an unfamiliar moral issue is encountered. Now, Samuel and Pearl Oliner's study, published as The Altruistic Personality, found that parents who modeled caring behaviors inside and outside the family were more likely to have children who would take significant risks to help others. Specific suggestions and techniques for modeling desirable behaviors are available through a number of sources. At healthychildren.org, suggestions include pointing out sharing among adults, showing ways to calm down, teaching children to express their feelings, and paying attention to good behavior. At klaschools.com, suggestions for modeling involve doing good deeds, being patient in lines, respecting others and their property, and being a good loser. Other sites also contribute constructive ideas. Now, literacy is the key to all learning. Early vocabulary growth comes with parents speaking frequently with their children. Brain growth is impaired when less words are spoken to children. The 0 to 3 program and others provide parents ideas for nurturing thinking and language skills. Unfortunately, across the United States, less than 50% of children are read to daily by parents. The Head Start program in the United States provides a vehicle for disadvantaged children to, quote, catch up. However, the program is inadequately funded and staffed to serve all of the many children in need. This lack of learning and impaired literacy in the early years may hinder the attempt to transmit plain moral facts through reading and telling stories. That is
Doctor,
why
we can't hear
promoting. You can't hear? That is why promoting early literacy has the potential of enhancing the moral and social emotional development of children. Do we hear that?
We can hear you now.
Can you hear? There are many resources that caregivers and schools may use to promote moral learning as children mature. For the lessons to be appreciated and internalized, it is obvious that comprehension is mandatory. Now, human relations programs for children are very helpful in promoting appropriate behaviors. Individual differences and experience in human relations for children is an example of a compendium that outlines exercises at various grade levels to sensitize children to appropriate interaction with others. Multiple goals of the exercises include furthering self-esteem, supporting virtues, and avoiding vices, control of emotions, awareness of human similarities, and respect for individual differences. A number of resources are available to teach respectful human relations. Many school systems do an excellent job in this area. However, it should be emphasized that there is a degree of moral entrepreneurship in all these programs. Such moral entrepreneurship involves expressing an opinion as to what is virtuous behavior and what behavior should be avoided, i.e., vices. In this regard, virtues are defined as those traits of character that blunt mere self-interest, so that one can see and actively promote the interests of others. In contradistinction, vices represent those traits of character that unleash mere self-interest, so that one fails to or ignores to see the interests of others. Certain cultures may vary somewhat in their concepts of virtues and vices. Teaching and agreeing on plain moral facts should be achievable. Now, false narratives have classically been a vehicle by which societies have attempted to direct members to accomplish their own selfish purposes. Such false narratives may distort history, promote false beliefs, and propagate negative feelings toward ethnic and racial groups for political purposes. It is anticipated that healthy psychosocial development that includes authoritative parenting and moral learning will shield persons from internalizing these false narratives and contribute to resilience in stressful times. Higher levels of literacy developed through the educational process should further facilitate the process of, quote, reading between the lines. There are communication skills that include attentive listening, assertive statements, and clear opinions that are essential to the success of nonviolent conflict resolution. Human relations programs for children should provide the basis for the objective thinking required to reduce enmities that have developed. Now, emotional empathy refers to the vicarious sharing of emotions. The ability to feel the emotional states of others is based on the quality of interpersonal and intrapersonal attunement experienced during development. Dr. Helen Reese has developed the concept of empathic concern and empathic capacity. It is secure, attuned attachment, model behaviors, reading stories with a moral, and human relations programs for children that contribute to enhancing emotional empathy. Unfortunately, interpersonal relationships marked by conflict, insecurity, and distrust can cause us to feel threatened, emotionally deregulated, and closed off to empathetic connection with others. There are many examples where recurrent maltreatment in childhood that results in fear and anger produces a stifling of emotional empathy. The presence of cognitive empathy, the ability to mentalize without emotional empathy, is characteristic of psychopathy, where ruthless persons use others as objects to satisfy their own selfish needs. Now, emotional empathy allows one to feel the suffering of others. Moral learning creates the impetus to care about such suffering. The result of feeling one's suffering and caring about it is the desire to relieve the discomfort. That desire we define as compassion. It is compassion that leads to helping behaviors that ultimately relieve the suffering. The propensity to work towards helping behaviors is clearly dependent on the quality of experiences during psychosocial development. Now, in conclusion, it is clear that optimizing psychosocial development is not a simple endeavor. If we are to achieve parenting for a peaceful world, significant initiatives are in order. Parenting orientation prenatally has been shown to be effective. Pediatricians can provide ongoing support to children and parents in the office if their services are readily available. Certain genetically transmitted conditions, mental disorders, congenital problems, and injuries require ongoing medical and community resources for the best possible outcome. The United Nations Convention on the Rights of the Child could provide a vehicle to further developmental education globally. There is much work to be done as the child advances through the school system. That work includes contributions from teachers, theologians, pediatricians, political leaders, and other community members who serve as role models for civility and responsible behavior. Indeed, it takes a village if psychosocial development of children is to be optimized. For progress to be made, countries need to provide the person power and financial resources to facilitate traversing the steps outlined in the two flowcharts, which we're going to conclude with in just a minute. Prioritizing efforts to achieve such progress is a challenge for all societies. And this is the flowchart that relates to our discussion. This is the path to benevolent mindfulness, starting with interpersonal attunement and authoritative parenting. We develop secure attachment, which promotes the internalization of the various types of learning, reading stories with a moral that teach a lesson, modeling of caring behaviors. And that secure attachment leads to this mindfulness or interpersonal attunement. The secure attachment, and the interpersonal attunement with parent and child, caretaker and child, enhances emotional empathy. The emotional empathy allows one to feel the feelings of others, the emotions of others, that leads to compassion, and the compassion leads to helping behaviors. Now, human relations programs for children and an enhanced literacy really help the development of resistance to false narratives, and human relations program for children teach and they can internalize a process for nonviolent conflict resolution. And I want to just go, the path we don't want to go to is the path of malevolent mindfulness. Often starts with authoritarian parenting, which produces repressed fear and anger. In a permissive type of parenting or an uninvolved parenting, in the presence of an authoritarian culture, we end up in the same pathway with this toxic stress, the repressed fear and anger. It results in a stifling of emotional empathy and a susceptibility in an authoritarian culture with group targeting via false narratives for all kinds of hatreds and enmities. Reinforcement of such false narratives through repetition and possible coercion results often in violence. And of course, in the authoritarian cultures where everyone is sort of programmed to do the same thing, then you have a whole group that is oriented toward violent activities. So this is definitely what we want to avoid. So I'm going to stop sharing for a minute here. I want to try and show a tape that outlines interpersonal communication and the importance of it. Here I'm going to click the share sound. I think this is going to work. And share. Okay. I'd like to make it bigger, but yeah, we can do that. There we go. Let's get back to the beginning. Okay. Should be able to show it now.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
Okay, that's the presentation. I hope you did hear. Someone said they didn't hear at some point. Thought I was talking pretty loud. If there's any question, be happy to answer.
Dr. Katzman, this is Dr. Rafael Acuña from Mexico City. What a
Yes.
Congratulations for your meeting, for your presentation, and what a wonderful video you just have showed us. Hospitals. This is the Navy hospital where I worked for 21 years. And I also work in my private practice. So the work that you're going to hear is from this Navy hospital. And the objective of this talk is to review our initial experience with cholangioscopy in obstructive biliary pathology in a third-level medical center. This is a frequent problem. Obstetric jaundice and especially cholelithiasis is a frequent problem. It's within the 10 main causes of abdominal pain. And you can see here a visible gallbladder. This is not the rib. Look, the rib is over here. And this is a visible gallbladder. I've never seen this before. This is a patient who had a pancreatic cancer, and you can see this sign of a visible gallbladder. So what is a cholangioscope? A cholangioscope is a frontal view endoscope designed for biliary tract and pancreas. It's a single use only and sterile with a working channel that allows to pass instrument. In our hospital, we started in 2016. So what's the problem? The problem was that cholangioscopy, it's really not new. It's been done since 1950 in open surgery and by endoscopy in 1970, but its daily use was rare. The movement of the tip was limited to only 2 directions, and endoscopes were fragile and not very functional. They had less light, because they were from fiber optic. They had to be re-sterilized. They were very expensive, and you needed 2 endoscopies to do the procedure. So in 2015, Boston Scientific produced the spyglass digital system with a double illumination. It's digital. It has a field of vision of 120 degrees, an angulation of 30 degrees. It has a better resolution, 2 controls for movement of the tip in 4 directions. You can see here the 2 controls of the cholangioscope. By the way, you can see here the black is the duodenoscope, and attached to it is the cholangioscope, and you can see here the laser fiber optic that is going through the channel of the cholangioscope. So the working, and especially two things very important, it has a double channel of irrigation and a working channel. In the cholangioscope has a working channel, so it can be therapeutic. And the first patient that we did in Mexico, I had the honor to do it in 2016 with the spyglass. And so this is the endoscope that we use. You can see that this one is attached to the duodenoscope. The cholangioscope in white is attached to the duodenoscope on black. And you need only 1 endoscopist, so it's easier to work with both endoscopes because there's no coordination. And so how do we do it? This is how we do it. We pass the duodenoscope, and then through the duodenoscope we pass the blue cholangioscope that you see in this slide. And on the right you can see an amazing view of the biliary tract. I never get tired of looking and watching these beautiful views because it's amazing for me to see what I have never seen before. All the interior part of the liver, sometimes of the pancreas. And so how we do it? How do we do it? We first start with taking it out, the endoprothesis, if a patient has one, and then we do an sphincterotomy in order to pass the cholangioscope that you see here in blue, and then we can do the treatment. You have 3 views. You have the fluoroscopy, the cholangioscope, and of course you also have the duodenoscope that you're not looking here, but you can see the primary stones on the right. You see the primary stones and how we are working, we're breaking. And so how to gain access? How do you do it? How do you gain access? We first pass a jack wire that you see over here, yellow with black, and then over the jack wire, we pass the cholangioscope And we always work as a team. This is a teamwork. This is all we are.
Doctor,
we are.
But as
Yeah.
you're presenting, can you click on the slide because we only see the first slide?
Oh, okay. Do you see it now?
No, just the first one.
Oh, I'm sorry. Okay. Okay. Here.
No, it's still the first slide.
Can you pass it?
Can you click on the second one or the like?
I already did. Oh, okay, let me see. Here. Hi, do you see it?
No, sorry, doctor, we don't see it. Can you scroll? Can you try to scroll?
I'm already doing it. Can you how do you fix this escape? Okay, can you see it?
Yeah, we can see it. We can see it now.
Okay, I'll do it like this. Okay, so this is the objective. You can see the cholangioscope going in. I was talking about this beautiful, I'm sorry, I'm gonna do it some things again, talk about something again. You can see a visible gallbladder. This is very important because maybe you won't see it again. This is the rib, this is the gallbladder, a visible gallbladder. For me, it's amazing. And so this is a frequent problem. The cholangioscope, you can see the cholangioscope here. I already talked about the advantages. That is the disadvantages that you heard. Okay, this is the double illumination digital. This is the characteristic of a spyglass. Digital double illumination, 120 degrees, field vision, angulation 30 degrees. It has better resolution to contrast of movement and a channel working channel. So this is how we do it. You can see that the cholangioscope in white is attached to the duodenoscope in black. And this is how we pass the duodenoscope and then the cholangioscope on the inner part of the duodenoscope. And this is the amazing view that I was telling you. I never get tired of seeing all the interior of the biliary tract or the interior of the liver, because as an endoscopist, this is not a very frequent view, as you can imagine. So how we do it, we first cut the papilla with the sphincterotomy, and then we pass this blue cholangioscope that, excuse me? Okay, this is the blue cholangioscope that you see on the right. And this is how you have the three views that I was talking to. The fluoroscopy, the cholangioscope, and the duodenoscope that you don't see. We have three screens. This is the biliary tract stones, mainly primary stones, very big stones. I believe that Dr. Acherinos will agree with me that these primary stones that are frequent in the hematological patients, especially you can see that this one is more green. So it might be from an hematologic problem. And so how we do it, we pass the jack wire, and over the jack wire, we pass the cholangioscope. We always work as a team, as you can see here. All together, we are always part of a chain, small pieces of a chain. So we always use prophylaxis. We use indomethacin, single dose, 100 milligrams before endoscopy, and antibiotics, usually cephalexin. So in order to stop pancreatitis or to prevent pancreatitis. And you can see here the duodenoscope and the cholangioscope in fluoroscopy, and the working channel that is passing the proof. we started doing the lithotripsy with the laser first, and then we changed to electrohydraulic, as you will see. So look at this slide. This is very important. In 3 years, we did 360 ERCPs. It sounds, se dice rápido. You can tell that very fast, but with 360 ERCP, believe me, it's a lot of work. You can see here that most of the RCPs, most of the patients went to ERCP because on the left you can see that we almost always can do the job by traditional ERCP. You can see here a very big stone coming out because I had the opportunity of do a very long cut on the papilla, and you can see a stone that is almost 2 centimeters. But this is not the rule. Sometimes it's very difficult. So only 4% of our patients, that is this little piece of the pie, went to cholangioscope. Unfortunately, because it's very, very expensive, but very, very useful. So the indications for cholangioscopy is multiple biliary stones that are 2 centimeters or more in size, with difficult geometry, because it's not only the size that matters. The cubic stones, the triangular stones, the cylindrical stone, it's impossible to take them out because of the geometry. It's going to get stuck. If you do a small sphincterotomy and you can't do a long one because the biliary tract is not dilated, there's no way. Undetermined stenosis is also an indication. And look at this. This was my first case, and I'm going to show you later the patient. He had 7 stones, 7 cubic stones that needed hours of hard-working work. Look at this, the cubic stones that we have to demolish, 1, 2, 3, and the endoscope is here, but you can count some more over here. So this is a retrospective study, series of cases solved by cholangioscopy. The variable studies were causes of biliary obstruction, type of lithotripsy, resolution rate, number of sessions for biliary clearance, complications, and mortality. Note that this is a single-center study. So in our study, we had most of the patients were female, as you can see. We had only 15 patients that went to cholangioscopy because of the criteria. They were the age range was from 25 to 89 years, and the median age was 73 years. Most of our patients were old people like me with very big stones. So the results is that the undetermined bile duct stenosis was the diagnosis only 1 patient. He had a cholangiocarcinoma that I'm going to show you. The biliary duct stones were 14 patients with 93.3%. And look at this, 66% of our patients, almost all of our patients, had previous ERCPs. 1, 2, 3, doing the same and having the same result of failure. So first session result with spyglass, with cholangioscopy, first session solved 82% of these very difficult cases. And we even needed a second session to resolve the 18%, but we did achieve the 100% results. The complications were mild pancreatitis in 15.3%, and the mortality was present in this patient of the cholangiocarcinoma. So the main use of the cholangioscope is lithotripsy. This is very interesting because it's not just looking or seeing or diagnosing, no. It's treating and breaking and solving in difficult stones. It also has the advantage of taking direct biopsies by forceps. And the forceps, by the way, is only 1 millimeters, and sometimes it's very difficult for the pathologist to process these biopsies. So you have to talk to him, because if you don't, the pathologist is going to say, you didn't send me nothing. There's nothing in the material you send me, because he won't even see them. You have to talk to him and to bring him to the endoscopic unit. It can be useful in pregnancy because there's no need to do radiation. So we did have one patient that was pregnant, so we didn't use radiation. She was 26 weeks pregnancy with colorectal. She had 4 hospitalizations for pain. We were trying not to do surgery, not to give her anesthesia, but there was just no way we could control this problem. So the case was solved by cholangioscopy, and she was the only patient that had a secondary stones. And this is how we do it. This is the energy. We first started using laser holmio, 1.8 joules at 10 hertz frequency. You can see the fragmentations of the stone. Look at this. And then we changed to electrohydraulic. That it's very safe, because you don't have to place even the proof near the stones. It's a matter of sparking the electrohydraulic force, and then it will produce a wave of that will break the stone. So and remember that the biliary tract, it's full of water while we are working. So the use of cholangioscope was for stones in 93%, and stenosis is in only 6%. And we had resolution in the first session for 82%, and the rest in the second session, just 2 sessions, or just 1. And we had primary stones in 93% of our patients, and those are the worst stones that you can imagine, because sometimes or especially because they form in the interior of the biliary tract. These are not stones that come from the gallbladder. These are stones that form in the biliary tract, and I have seen stones that even have the form of the biliary tract, like a coral. Can you imagine that? So this is something that is very difficult. So how much has this changed the treatment? This is a meta-analysis, a beautiful meta-analysis from Dr. Robert G. Wang et al., done in the United States, in the whole United States, and you can see 15 years of study in the whole United States. So look at this. These are all the cases in gray from the United States. You have the years here in the bottom, and you have here also the rate of the procedures. What do we do with those patients? And you can see that ERCP is going up all the time, almost paralleling the other cure. We no longer do diagnostic ERCP. You can see the yellow is diagnostic ERCP, and it's almost gone, because we do cholangiotomography or cholangioresonance, and so we no longer have to do a diagnostic ERCP with the risk that implies. And bile tox surgery, I'm a general surgeon, but it's almost gone, because we almost always have solved the cases by endoscopy. And percutaneous transhepatic cholangioscopy or cholangiography, it's rarely done because you have to puncture the liver, but it's a very valuable tool. We have also a short version of the SpyScope that can be introduced by the liver for the very special difficult stones that are in a certain part of the liver. So this is how we used to do it. This is what I learned when I was a resident many, many years ago. I know how to do this surgery. You have to place this kind of the drainage, that is the care drainage. And the care drainage, listen to this, the care drainage is no longer produced, it's gone. So if you have one, you have to place it in a very special place in your hospital, because if you might need it, and if you need it, you won't find another one. This is something very valuable nowadays if you have to do a surgery, because it's no longer produced. But you had to have the drainage for 1 month. And so this is what we used to do. In stenosis, the cholangioscopy has a high sensitivity and specificity only by endoscopic image. Only by endoscopic image, you have a sensitivity of 90% and a specificity of 95%, with a positive predictive value of 94% and a negative predictive value of 92%. And I'm going to show you what to look. What to look in a malignant stenosis? Of course, the stenosis, but look at this pattern, nodular pattern, that's malignant. Look at these digital formations inside the biliary tract, that's malignant. And especially the first sign and the most important, if you see these blood vessels that are curved, spiral in sacacorchos, I don't know how to, spiral sign, that's 60% positive just for the image. The correlation is 60% positive. So the complications we had, they were all achieved, or they were all attributed secondary to the sphincterotomy that we have to do. It was malpancreatitis in 2 patients that solved in 48 hours. So the indomethacin, it's very valuable because it will prevent, but if it doesn't prevent the pancreatitis, the pancreatitis will be mild. It will be something very mild comparing if you don't administer indomethacin, but it has to be rectal indomethacin or diclofenac, because it's the only way you can prevent. And complications from cholangioscopy were none in our series, but remember, it's a small series. And in the literature, it's up to 3%, and you can have perforation because of especially because of the water. If you have, like, look at this, you have an stenosis, and if you keep on pushing water in, you can have 2 things. First, you can perforate the biliary tract, and second, if the patient has sepsis, like in this one, you can see the jet of pus coming out. You can do sepsis, and you can do bacteremia. So that's why you have to put antibiotic. This was a patient of the cholangiocarcinoma. This patient died 24 hours after the procedure, and that was because the patient was already in septic shock, and even in septic shock, we tried to do our best because the patient was not going to survive. We tried to passage a wire. We were not able to try to place an endoprothesis, but it wasn't possible. So, in summary, cholangioscopy is a new endoscopy tool in daily practice that complements ERCP. The principal use was for treatment, so that's very gratifying. We had primary biliary stones in 93.4%, and I believe that Dr. Achirinos will agree with the hematological patients. And the resolution rate was 82% in the first attempt. In the second attempt, 18% for 100% clearance of the biliary tract. The complications were mild pancreatitis in 2, for 13.3%, and the mortality was present in one patient who had cholangiocarcinoma in 6.6%, she was in sepsis. And another advantage is that it's a short hospitalization, normally only one night. And note that this is a retrospective study, a small series within a single center. But one patient, only patient can change everything. And this was my first patient, and I have the permission to pass this picture. This is Hugo. When he came to me, he had already 3 ERCPs with failure, and I really didn't know what to do another ERCP, to open the abdomen and do a direct surgery, but I did try to do my best. Unfortunately, I thought about cholangioscopy, and so one patient, one only patient, and that's why we started doing cholangioscopy in our hospital and treating those patients like this. And the first case in Mexico City was done with a spy scope, was done in the Navy hospital. So one patient can change everything if we do our very best, and of course, work as a team as we always do in the Navy. This is my ship, by the way. So thank you very much. I will glad to answer your answers to your questions. If you have some questions, and this is my presentation. Thank you very much.
Thank you so much, Doctor. That was a wonderful presentation. As the doctors, if you have any questions, drop it in the chat box or turn on your mic.